My name is Jeong from Yonsei University, Korea, and topic is about impact of fluorescent lymphography on lymphadenectomy quality in reduced port gastrectomy. I have no COI to disclose. Radical gastrectomy requires ligation or preservation of major vessels and adequate lymphadenectomy with precise dissection along these vessels. The technical quality of lymph node dissection is one key component of oncologic gastrectomy. To perform the same oncologic surgery in a less invasive way, the reduced port gastrectomy has been introduced. This approach may offer several advantages, such as less invasive, less abdominal wall trauma, better cosmetic outcomes, and faster post-operative recovery. However, it is technically demanding with limited exposure and transaction leading to difficulty in complete lymph node dissection. Fluorescent lymphography is a navigation technique that visualizes the lymphatic drainage from primary tumor using the ICG and NIR images. And after injecting ICG at the submucosal layer preoperatively by the endoscopic, it allows surgeons to identify fluorescent loads in real time during the lymphadenectomy, and may also facilitate more thorough lymph node dissection during the surgery. The previous studies have suggested that the FL can increase lymph node retrieval and reduce non-compliancy and high sensitivity and negative predictive value for predicting metastatic lymph nodes, and this leading to survival benefits. However, most of these data came from a conventional multi-port gastrectomy, and whether the FL can compensate the limitation of reduced port gastrectomy remains unclear. So therefore, the aim for this study is to evaluate association between quality of lymphadenectomy and the FL during the reduced port gastrectomy. In this study, reduced port gastrectomy included three different methods: the laparoscopic three-port way and the Da Vinci Xi system, with the single-site method and the single-site materials and the Da Vinci SP system. This is the study profile. After the exclusion, 769 reduced port gastrectomy between the February 2014 and June 2025 were included. And this was performed by 3 operators. Most of the non-FL cases were resulted from practical issues related to preoperative the endoscopic ICG injection, including the scheduling limitation around weekends or holidays, and the ICG injection failure or the application of FL or reduced port gastrectomy period. So therefore, the propensity score matching included confounding factors such as OP, the operation year, and the operator. So after the propensity score matching analysis, the FL and non-FL group included 196 patients respectively. The quality of lymphadenectomy included number of retrieved lymph nodes and the non-compliancy rate, which was defined as more than 2 intended lymph node stations not removed. And the survival outcomes included the relapse-free survival and the overall survival. This is the results. And in clinical and surgical characteristics of patients before the propensity score matching, there were significant discrepancy in AH, operator, method, and OP year and extent of lymph nodes dissection, but after the propensity score matching, the standardized mean differences seems to relatively well balanced after the matching. So this is the clinical and surgical characteristic after the propensity score matching. And you can see that most of the surgeries were performed by one surgeon and mostly done by the XI plus the single site, and mostly performed in distal gastrectomy and D1 plus lymph node dissection, and most of them were pathological stage 1. The number of lymph node retrieval showed significantly higher in the FL group, and patients of lymph node retrieved more than 15, 25, and 30 were higher in the FL groups. Although the FL group showed lower non-compliancy rate compared to the non-FL group, it was not statistically significant. The station-specific analysis showed that the station number 3, 4D, and 7, 8, and 9 were significantly more retrieved, and for the 7, 8, and 9 may reflect the improved dissection in the technically demanding suprapancreatic area. And in contrast, we think that the station number 3 and 4D, the higher retrieval may be more related to the better identification and retrieval of the fluorescent lymph nodes within the resected specimens. The relapse-free survival and overall survival among total cohorts showed no significant difference between two groups. And relapse-free survival and overall survival also showed no significant difference among the stage 1 patients. And among 2 and 3 patients, the relapse-free survival appeared slightly better in the FL group, but the statistical difference, there were no statistical difference, and either of the RFS and the overall survival. And probably the one possible explanation is that although the fluorescent lymphography improved the nodal retrieval, it did not significantly improve the non-compliancy rate. So therefore, the quantitative advantages may not have been sufficient to improve the survival benefit. And in addition, most of the patients were early stage, so the survival events was limited. So in conclusion, the FL-guided lymphadenectomy increased the lymph node retrieval in reduced port gastrectomy, and this might be useful tool when lymphadenectomy is technically demanding. However, its impact on long-term oncology outcomes remains uncertain in reduced port gastrectomy. Thank you.
Thank you for a kind introduction. Today I'm going to talk about the natural course of anastomosis or stump leakage following gastrectomy for gastric cancer patients. I have no COI. So anastomotic leakage after gastrectomy is known to occur in 0.6 to 10% of the patients. And anastomotic leakage after gastrectomy is associated with increased morbidity and mortality. Therefore, early detection and effective treatment of leakage is critical. Management of anastomotic leakage is generally based on the individual surgeon's experience. But optimal management of leakage still remains controversial. Also, studies evaluating incidences and treatment results for anastomotic leakage are scarce. Purpose of this study is to investigate the real-world diagnosis and management strategies according to each type of leakage, and to evaluate the natural course after the detection of leakage with a focus on management approaches, treatment duration, and failure to rescue outcomes. This is a multi-center retrospective study of the patients who underwent the subtotal or total gastrectomy for gastric cancer between 2010 and 2022. 8 affiliated hospitals of the Catholic Medical Center participated, and clinical pathological characteristics, oncological, and postoperative outcomes were stratified according to whether the patients were FTR or not. And FTR is defined as anastomotic leakage associated with the 90-day mortality or more than 8 weeks of hospital stays. Out of 14,000 patients, data of 345 patients with leakage were included. After exclusion of insufficient data, 271 patients were analyzed. So total anastomotic leakage incidence was 1.9%, and total gastrectomy leakage was 4.3%, and distal gastrectomy was 1.2%, and proximal gastrectomy was 4.7%. 81% were male patients, and 25% of the patients had a diabetes, and 61 patients underwent the laparoscopic approach. Also, for this distal gastrectomy, villus 2 reconstruction was the most common. This is the perioperative results. Mean leakage detection day was post-operative day 9, and the most common leakage site was esophageal jejunostomy, followed by duodenal stump leakage, and the most common leakage detection method was CT. And Cleveland-Dindo classification higher than 3B was defined as severe AL, and it was about 40%. The most common management was stent insertion, most of which is for EJ leakage, and drain such as pigtail insertion was next most common method. 20% of the patient underwent surgery for leakage management, and for other complications, pulmonary-related complications were the most common. This table shows the risk factors of FTR patients. According to univariate analysis, old age, cardiovascular disease, and intraoperative transfusion, and EJ leakage and reoperation were the risk factors, but according to the multivariate analysis, only intraoperative transfusion and reoperation were risk factors. This is the Kaplan-Meier curves for 5-year overall survival for moderate anastomotic leakage group and severe leakage groups. Overall survival was 79.4%, and moderate was 97% of survival, and severe group was 67%. This graph and table represent the management duration and success rate according to leakage types. Each leakage's mean detection day was about POD 9, which is red bar, and the most common detection method was CT. And for EJ leakage, stent insertion was the most common management. For stump leakage, pigtail was the most common, and for gastroduodenal leakage, surgical treatment was the most common. This blue bar represents the hospital stays. EJ leakages hospital days were the longest, and success rate for initial treatment is green line, and initial treatment for duodenal stump was the most successful. Also, FTR is yellow line. FTR was about 20% in EJ leakage, whereas stump leakage it was only 8.7%. So these are key results of this study. So EJ leakage was the most common, and CT was the most common method to diagnose leakage. And for management, stent insertion was the most common for EJ leakage, and pigtail insertion was the most preferable treatment for duodenal stump leakage. And for gastroduodenal leakage, reoperation was preferable. FTR was 15.5%, and leakage-related mortality was 8.5%. Logistic regression analysis showed that intraoperative transfusion and reoperation were associated with FTR. This is my conclusion. Leakage remains a critical problem following gastrectomy for cancer. Early diagnosis, nutritional support, and sepsis control are essential for safe management of leakage, and decision of reoperation should be careful because recovery failure after operation is probable. Thank you for your attention.
Thank you. Good afternoon, distinguished professor and colleagues. My name is Yun-Suhk from Binh Hospital and from the University of Medicine in Ho Chi Minh City, Vietnam. Today, I would like to present my entire study, namely clinical utility of the Phuoc score in guiding laparoscopic strategy for perforated peptide ulcer, the prediction of mortality and conversion risk. Before I begin, I would like to declare that I have no personal or financial interest related to this presentation. Picture is allowed during my presentation. So as we know, peptide ulcer disease remains a common gastrointestinal condition worldwide, affecting more than 4 million individuals each year. And among its complications, perforation represents one of the most severe surgical emergencies, occurring in 5 to 10% of patients, and we reported mortality rate ranging from approximately 23 to 40%. As we can see, PPU is a condition which can be treated successfully with a combination of surgery, sepsis control, and personalized treatment for each patient. And among them, early identification of high-risk patients is therefore crucial for optimizing peri-operative management and improving surgical outcome. Over the past decades, laparoscopic surgery has increasingly been adopted in the treatment of perforated peptide ulcer. Compared with open surgery, laparoscopic repair offers several advantages, including reduced post-operative pain, shorter hospital stay, and faster recovery. However, the rate of conversion from laparoscopic to open surgery remains relatively high, with reported rates range from 8 to 44% in several studies. This highlights the importance of appropriate preoperative patient selection. So to improve risk stratification, several scoring systems have been proposed. For example, ASA and BOY score. ASA is a score that evaluates the overall physical status from 1 to 5, with high grade 3 to 5 links to increase PPU mortality. This is widely used but less specific to PPU than other scores. And BOY assigns 1 point each for the major comorbidity, preoperative shock, perforation duration is more than 24 hours, and mortality rise, which is ingredient score, is simple, validated, and strongly predict outcome. Over time, from history to date, due to the developments of statistic analysis and emerging of electronic medical record, many prognosis calculated tools have been developed on online platform. We combine data as much as possible in order to increase the positive probabilities to diagnose and enhance the quality of treatment of peptide ulcer perforations. Among them, the peptide ulcer perforation score, means BUP score, issued by 2012. It is used preoperatively for risk stratification. It's induced by Moller in 2012, integrate a clinical variable, and has demonstrated good predictive performance for mortality, with the score ranging from 1 to 18. In patients with score below 8, the mortality rate is less than 25%. In comparison to those who have scored more than 8, which rate is less than 25%, increase the probabilities to have adverse event more than 25%. In the original cohort, the score achieved an area under a ROC curve approximately 0.8 for mortality prediction. But despite its usefulness, the role of BUP score in the guiding laparoscopic surgical strategy and predicting conversion risk remain unclear. So the result of LAMA trial confirmed that laparoscopic correction for PPUs is safe, feasible, and less post-operative pain. Despite the operating time were longer in the laparoscopic group, but there were no difference in the length of hospital stay or the incidence of post-operative complication overall. Therefore, the aim of our study is to evaluate the clinical relevance of the BUP score in patients with perforated peptide ulcer score. Specifically, we aim to assess its performance in predicting the 30-day post-operative mortality and conversion from laparoscopic surgery to open surgery. So we conduct a retrospective cohort study including 384 patients who underwent emergency surgery for the perforated gastric duodenal between 2012 and 2025. Pre-operative clinical and laboratory data were collected, and the BUP score were calculated for each patient. Multivariate logistic rejection analysis were performed to identify independent predictors for mortality and conversion. Predictive performance were evaluated using ROC group analysis and compared with the BOY score and ASA classification. Looking at our results, the mean age of our patients were 55 years, with a strong male predominant with a males to female ratio of roughly 4 to 1. Over 84% present with a sign of peritonitis. Anatomically, most ulcers were located in the duodenal bulb and the pyloric region, consistent with previous reported epidemiological pattern. In addition, the majority of post-perforation were relatively small, with a size less than 10 millimeters in more scale. Regarding surgical technique, 82% had a primary repair, others require augmental patch. Other complex cases require tubeostomy, RNET, or even gastrectomy. In our study, the overall post-operative mortality rate was 5.7%. Among patients initially undergoing laparoscopic surgery, the conversion rates to open surgery were 22%, dividing and consistent with previous reported conversion rates in the literature, with a mortality rate of 5.7%. When we evaluated above score performance for mortality, the result was exceptional. Using a threshold of 8 or higher, the model showed a sensitivity of 86.4% and a specificity of 92%. The difference between the low risk and the high risk group were highly significant, with the p-value is less than 0.001. And multivariate analysis identified 3 independent predictors of post-operative mortality, including malignant or HIV infection. The second is symptom of duration longer than 24 hours. And the third one is elevated serum creatinine greater than 130 micromole per liter. The factors reflect the combined impact of systemic illness, delayed presentation, and organ dysfunctions on surgical outcome. With the conversion rate of 22%, using a threshold of 4 or higher, the model shows a sensitivity and a specificity roughly 50%. The difference between the low risk and the high risk were not significant. Regarding conversion from laparoscopic to open surgery, our risk stratification of the conversion model analysis demonstrates that elevated serum creatinine was the only independent predictor. Patients with a creatinine level above 130 micromole per liter had a significantly higher risk for conversion, with an odds ratio of about 2.9. Other components of the BOOP score did not show the significant association with the conversion risk. So receiver operating characteristic analysis demonstrate that the BOOP score excellent discrimination for mortality, with the area under the rock curve was 0.965 with a cutoff point at 6.5. As you can see, in the rock curve comparison, the BOOP score achieved the largest AUC of 0.965, outperformed both the BOY score and the ASK score. This confirms that the BOOP score is the most accurate tool currently available for predicting mortality in a PPU patient. Interestingly, regarding the surgical conversion, the BOOP score did not perform as strongly. The AUCs were only 0.5, which were not statistically significant, while elevated creatinine remained a specific risk factor. The total BOOP score at the composite index appears to be the poor predictor for the technical necessity for conversion. Our findings suggest that the BOOP score is a highly effective tool for early mortality risk stratification in patients with perforated peptide ulcer. It can support clinical decision-making regarding preoperative management, including intensive monitoring and resource allocation. Perioperative planning. However, the risk of conversion appears to depend more strongly on technical and anatomical factors that are not fully captured by the BOOP score. In conclusion, our findings suggest that the optimal cutoff for mortality is 6.5. Patients with a score 7 or higher should be considered high risk. The BOOP score demonstrates excellent performance in predicting post-operative mortality in patients with perforated peptide ulcer. While it may assist the guiding perioperative decision-making, its ability to predict conversion from laparoscopic to open surgery is limited. Conversion risks require additional clinical and operative variables. Future study incorporating additional operative and anatomical variables may further improve prediction model of laparoscopic surgical strategy. So thank you for listening.
Good afternoon. I'm Jawon from Yonsei University. I'm going to present about our study comparing oncological outcomes of D1 plus versus D2 lymphadenectomy for clinically node-negative upper third advanced gastric cancer. I have no COI. The optimal extent of lymphadenectomy has long been one of the most debated debated topics in gastric cancer surgery. Currently, D2 lymphadenectomy is regarded as the standard procedure for all but T1 and 0 tumors in order to achieve accurate staging and effective local control. However, if preoperative clinical staging already predicts node-negative status, the rationale for D2 dissection changes significantly. In such cases, there's possibility that D2 lymphadenectomy would serve a merely prophylactic purpose. So we had this question: is D2 lymphadenectomy still necessary for patients who are clinically expected to be node negative? Previous meta-analyses, including the work by the Italian group, Dutch trial, and MRC trial, demonstrated that the survival benefit of extended lymphadenectomy was observed only in node-positive patients, but not in node-negative patients. Therefore, this ongoing trial called EDICT trial is investigating D1 plus versus D2 dissection for stage 1B and stage 2 advanced gastric cancer in the setting of distal gastrectomy. However, no study has yet evaluated the survival outcomes of D1 plus lymphadenectomy specifically for upper third advanced gastric cancer requiring total gastrectomy. Therefore, the purpose of our study was to compare the survival outcomes of D1 plus and D2 lymphadenectomy for clinically node-negative, serosa-negative upper third advanced gastric cancer. This was a retrospective study, and patients with upper third gastric cancer with clinical stage T2 to 3 and 0 stages were eligible for the study. This was our exclusion criteria, and we performed propensity score matching in order to achieve balance between the D1 plus and D2 lymphadenectomy groups, and then we compared the survival outcomes. As a result of checking the eligibility, there was a total of 478 patients who were eligible for the study, and we excluded 47 patients with distant metastasis, 108 patients with serosa-positive tumors, 11 patients with double primary tumors, 1 patient who received PPPD previously, and 9 patients with incomplete data. As a result of propensity score matching, we had 41 patients in each group, and the covariates including age, sex, tumor size, histology, neoadjuvant chemotherapy, surgical approach, pathologic stages were all well balanced. Looking at pathologic outcomes, the number of metastatic lymph nodes were comparable between the D1 plus and D2 groups, and the proportion of patients with lymph node yields higher than 16 or higher or 29 or greater were similar between the two groups. However, the D1 plus group had a fewer number of total retrieved lymph nodes. Also, the two groups had a similar proportion of patients who received adjuvant chemotherapy. In terms of surgical outcomes, there was no significant difference in operative times, estimated blood loss, major complications, and length of hospital stay. Now, moving on to the survival outcomes. During the median follow-up of 84 months, the 5-year overall survival rate was 84% in the D1 plus group and 84% in the D2 group, with no statistical significance. Similarly, the 5-year relapse-free survival was 80% for the D1 plus group versus 79% for the D2 group, with no statistical difference. So the survival outcomes of the D1 plus and D2 groups were comparable. When we examined the recurrence patterns, there was no significant statistical difference in overall recurrence rates, although the recurrence rates were higher in the D2 group. There were 3 patients in the D1 plus group who recurred, and 7 patients in the D2 group. There was no case of local regional recurrence, and the distribution across hematogenous and peritoneal recurrence was also similar. There was no lymphatic recurrence for the D1 plus group, and just 1 patient in the D2 group. So the recurrence patterns were also similar. We also analyzed the incidence of lymph node metastasis in stations number 10, 11D, and 12A. the metastasis rates at these stations were extremely low, 3% for station 10 and 4% for 11D and 0% in station number 12A. Also, 67% of the entire study group was pathological node negative, and 97% of the patients were also node negative in the extraperigastric stations, so the N2 tier. In conclusion, in this study, survival outcomes were comparable between D1 plus and D2 lymphadenectomy groups after total gastrectomy for upper third clinically node negative advanced gastric cancer. This could be possibly due to the low metastatic rates of those stations, number 10, 11D, and 12A, making their therapeutic index low. We acknowledge the limitations of this study, including the small sample size and the selection bias, and also 60% of the study group were ultimately classified as pathological stage 1. Nevertheless, our findings suggest that D1 plus lymphadenectomy could be selectively considered as a viable surgical option for clinically node negative patients with upper third advanced gastric cancer. Thank you.
I want to present our TEM, Moscow Clinical Scientific Center, long-term outcomes of endoscopic treatment non-ampullary duodenal tumors. Endoscopy is the primary method for treating benign neoplasms of the duodenum. Difficulties arise from anatomical features and the complexity of the manipulation. And there are high risk of complications both intraoperative and postoperative. It's important to properly examine the duodenum during diagnostic procedures. It's important to pay attention. Examination of all parts of the duodenum, examination of all wards of the duodenum, relation to the major duodenal papilla, the safe distance is 2 centimeters, size of the neoplasm and circumferential. There are several methods of endoscopic removal of neoplasms: endoscopic mucosal resection, endoscopic submucosal dissection, full thickness resection, mixed resection techniques. The choice of treatment method depends on the type, location, and size of the neoplasm. Experience of the Moscow Clinical Scientific Center between 2014 and 2026, 119 surgeries were performed for non-ampullary duodenal neoplasms. The number and types of operations are presented on the slide. By localizations, duodenal bulb and bulboduodenal junction 77 operations were performed, vertical part duodenal 88 operations were performed, lower horizontal part of the duodenum 15 operations were performed. Complications included bleeding, fluid collection, pancreatitis, perforation, and 2 patients had lethal outcome. Circumferential involvement excited 15% in all cases. Histological examination of the removed neoplasms is presented on the slide. Long-term outcomes: no strictures were detected. Relapse was detected in 30 cases. 9 cases removed endoscopy. FTRD systems used 2 cases. Endoscopic mucosal resection removed 7 cases. 5 cases performed duodenal resection. To reduce the risk of complications, it's necessary to close the post-resection defect. This is a neoplasm in the duodenum located on the health circumference. We performed an injection on saline solution into submucosal layer. We get a good lifting effect. After that, the neoplasm was removed by fragmentary mucosal resection. We can see a mucosal defect. If needs closed endoscopy clips, 5 clips used. This is a neoplasm is larger, involving several folds and whole the circumferential. We performed an injection on saline solution into the submucosal layer. We got a good, good at the lifting effect. The neoplasm was resected in multiple fragments. The defect was larger. We used an endoloop to close the defect. The endoloop is passed parallel to the endoscope and leads freely in the duodenum. After that, the endoloop is fixed to the mucus with endoscopic clips. The endoloop is then tightened. The mucosa is tightly fixed. This is the lipoma. It's located in the duodenal bulb. It was removed by submucosal dissection. A Q-type knife was used for the dissection after injection saline solution submucosal layer. We can see defect. The defect was closed with endoscopic clips. This is the removed lipoma, 7 centimeters. And the final video, this is a submucosal neoplasm located in the duodenal bulb. We performed an injection of saline solution in the submucosal layer. The neoplasm was removed by submucosal dissection. After removal, a damaged muscle layer is seen. The defect was closed with an Avesca clip. Mucosa is fixed. Conclusions. Endoscopic intervention on the duodenum are associated with a high risk of complications. Circumferential spread of more than 15% increase the risk of complications. Techniques for closing the post-resection defect reduce the risk of complications. Thank you.
Thank you, Chairman, for kind introduction. This is the last presentation of this session, mainly surgical videos without complicated tables or figures, so please enjoy. I have no COI to disclose. There are 2 major reconstruction methods after proximal gastrectomy, double track reconstruction and direct esophagogastrostomy. Today, I would like to present our initial experience with the double flap technique, with particularly focusing on technical refinements. Several studies have demonstrated better nutritional outcome after double flap reconstruction compared with total gastrectomy, less weight loss, and better nutritional parameters, including total protein, albumin, and hemoglobin. Recent meta-analysis also showed better post-operative BMI and hemoglobin after 1 year compared with double-track reconstruction. At our center, laparoscopic proximal gastrectomy with double flap reconstruction has been performed since January 2025. Initially, the indication was limited to clinical T1 and 0 disease, but recently we have expanded it to clinical T2 and 0 cases. We routinely check tumor distance from EG junction on endoscopy. For true LC side, distal tumor margin should be within 4 centimeters from the EG junction. For anterior posterior wall or GC side, the distance can be much longer. Of course, for fundus cancer, the distance is generally not important. Laparoscopic double flap technique is technically challenging because it requires intracorporeal hand-sewn anastomosis. At our center, we have a long experience of manual suturing and procedures such as staple hole closure and duodenal stump reinforcement. These procedures form the basis for adopting double flap technique easily. Now I'd like to review the double flap technique step by step with a video. First, trimming and transection of the esophagus. Similar to total gastrectomy, the lower esophagus is mobilized, trimmed, and then resected. Okay, and then hiatal dissection is important to hiatal dissection is important to secure sufficient length for anastomosis. And then the esophageal stump is retracted to anterior abdominal wall by barbed sutures, exposing the posterior wall of the esophagus. Sorry for no video of the flap creation. After proximal gastrectomy, the flap is usually designed at about 2.5 by 3.5 centimeters. Avoid injuries in submucosal vessels is important. After the flap creation, marking each edge is very helpful for orientation and accurate suturing during anastomosis. Return to laparoscopy. The proximal submucosal bed is first fixed about 5 centimeters above the esophageal stump. 3 barbed sutures are placed at both lateral edges and 1 in the center. Yes. And then after removing the esophageal staple line, posterior wall anastomosis is performed. Confirming the esophageal lumen here and marking is very helpful for maintaining orientation during anastomosis. And then 3 guide sutures are placed first for both edges and 1 in the center. And then barbed running sutures, 3 or 4 stitches on each side, from left edge to the center, and then right edges, and from right edges to the center. And then posterior wall anastomosis is completed. And then anterior wall anastomosis is done, again using barbed sutures from both edges with 3 or 4 stitches. The anterior wall is closed in 2 layers, muco and submucosal layer, and then seromuscular layer. Yes. Here, the first layer is closed, and then seromuscular suture is done. Key technical point is to avoid over-tightening. Excessive squeezing during suturing can cause narrowing of anastomosis and may lead to stenosis. Finally, a flap closure is done from lower edges of the flap, and then middle, and then upper edges. Same as anastomosis, 3 or 4 stitches for each side. Again, excessive tension should be avoided. Yes. Okay. This is surgical outcome of our 12 patients who underwent proximal gastrectomy with double flap reconstruction. Average anastomosis time is about 1 hour. Initially, the flap size was uniformly designed at 2.5 by 3.5 centimeters, but more recently, we have modified the flap size according to each patient's esophageal diameter and length. Some patients have a very close distal resection margin, but negative resection margins were achieved in our patients. There was only one complication case, anastomotic stricture, that developed 5 months after the surgery. This patient was our second case of double flap. It was successfully managed with a single session of endoscopic ballooning. Because our experience is still limited, long-term outcome is not available now, but so far, no patients have developed reflux esophagitis. In conclusion, first of all, familiar to laparoscopic suturing is essential. Second, flap size may be modified to esophageal diameter of each patient. And third, less stitches and avoid over-tightening, because excessive stitches and over-tightening may lead to anastomosis stricture. Finally, for accurate anastomosis, marking of both the flap and the esophagus may help accurate orientation and precise suturing. Thank you for kind attention.